Hi, everyone. We're in the middle now of a few lectures on a very important study that's ongoing here at Harvard, the VITAL study. And when I first introduced Joanne Manson, who's giving you a few lectures already on the VITAL study, I mentioned that she was going to be part of a team because the study involves many investigators. Well, the second person who's going to be presenting information about VITAL is my friend Julie Buring. Like Joanne, she's professor at the Harvard Medical School and professor of epidemiology here at the School of Public Health. You'll be seeing her again when she takes on another role of presenting a paper for a critique of literature exercise. But right now I'm asking Julie to continue building on the lectures that Joanne Manson gave about the VITAL study. So, Julie, the floor is yours.
Thank you, Fran. I'm very pleased to be here to talk more about the vitamin D and omega-3 trial called VITAL. When Joanne Manson did the first two segments about this trial, she talked about the rationale for doing this study, to be studying vitamin D and fish oil, and she talked about also the basic design of the study. What I would like to do in the next sessions is talk about actually the implementation of a study, of a randomized trial, from the standpoint of the investigators and also from the standpoint of the participants in the study. If we review for just a second the basic design of the study, which Joanne Manson explained to you, we have a trial in which we have 20,000 men and women, men over the age of 50, women over the age of 55, and they're initially healthy, which means that they have no evidence of cardiovascular disease and cancer. We're going to try to prevent those diseases by seeing whether vitamin D or fish oil will be effective in this way. What we did in the trial is take those 20,000 people and divide them into two groups. One group that would get vitamin D and placebo, and then another randomization where the groups would be divided again into those getting fish oil and placebo. So if you look at it from the diagram, we take our 20,000 initially healthy men and women, and we take them and we divide them into two groups. One group is randomized to receiving active vitamin D and the other to receiving placebo. And then we take those two groups and divide them again. One half of the group that got vitamin D will be receiving active fish oil. The other half will be receiving placebo. And of those who got the placebo to vitamin D, half of them will be receiving active fish oil and half of them will be receiving placebo. So our 20,000 people are divided into two groups. 10,000 get vitamin D and 10,000 get vitamin D placebo. Then randomized again, so those 10,000 who got vitamin D, half of those, or 5,000, got active fish oil, the other 5,000 did not. And of those who got vitamin D placebo, the same division into half getting active fish oil and half getting placebo. The trial will go on for a mean treatment period of 5 years. We're going to be collecting blood in as many participants as possible. We're hoping to do it among 16,000 at baseline with some follow-up in another 2,000. And on all of these people, we're going to be looking at our primary outcomes, which are cancer and cardiovascular disease. And for cardiovascular disease, we'll look at a myocardial infarction, a stroke, and dying from cardiovascular disease. So that's the design. But from an implementation standpoint, from a very practical standpoint, wherever are we going to find 20,000 healthy men and women who are willing to be in the trial, be willing to be randomized to getting vitamin D or not, or fish oil or not? Where do we get these participants in the study? And to really understand that, we have to go back just one step to thinking about the broader issues of the population hierarchy of a randomized trial. In a population hierarchy, we always have the big group, the group to whom we want to generalize our findings at the end of the study. And in this particular example with vitamin D and fish oil, we wanted healthy people who had never had a heart attack or cancer before, and we wanted to see whether we could reduce their risk of getting it for the very first time. So yes, the study is being done in the United States, but what we want to be able to do is generalize it to the broader population of everybody in the world who does not have evidence of cardiovascular disease and cancer. So that's going to be our reference population. But in reality, we can't do a trial among everybody in the world who has not had heart disease and cancer. What we need to do is define an experimental population, the actual population in whom the study is going to be done. And usually what we do is limit our population to one in whom we can give them the medications, we can work with them to comply with the taking of the medications, we can follow them up over time so we can get information on the outcomes from them. And we usually will limit it geographically, and we may limit it in a host of other ways to peoples that we will be able to get a valid or a true result in. So we take our reference population, we constrict it to a population in whom we feel we can get a valid or a true answer, and this is the population we invite to be in our study. We're going to assign them whether they get the drug or not, but they decide themselves whether they want to be in the trial or not. So when we send out our invitation, some of the people that we send an invitation to say, no thank you, I'm really not interested in doing this for whatever reason. Could be medical, it could just be preference. And we're going to try to get a sense of who is participating in the study and who is not. But now we begin to concentrate on the participants in our study. The ones who say, yes, I am willing to be in your trial. And it's always interesting to ask them why, and that's going to be important information in terms of trying to convince people or also tell people what they will get out of being in the study. But not only are they willing, but they have to actually be eligible. So the willing and eligible people are going to be our participants, and they are the ones that we are going to randomize to vitamin D or placebo, fish oil or placebo. We are going to then have our groups. We record whether they comply or not with the taking of the medications, and then we follow and we see what happens to them over time. But for right now, let's go back to those participants. Again, I can't figure out whether they're compliant or not or what their outcome is if I don't have the people in the study. So what do I need to think about to get 20,000 people in a study as an investigator? Well, first we have to decide what our eligibility criteria are going to be. What kind of people do we want in our experimental population? Well, we decided we wanted men over the age of 50 and women over the age of 55. And that's not because that's some magic group that's of most interest to us. It's when rates of heart disease and cancer begin to rise in the population. So we wanted to take a group that was old enough for these diseases of cardiovascular disease and cancer to be major factors of their morbidity and their mortality. It would be wonderful to take a younger group to start giving these interventions when someone's 20 years old and see whether that makes a difference or not. But you can imagine how long we would have to follow those people to get to the point where they began to have the endpoints that are of interest to us in our study. So we compromise. And we take a population when the rates of cardiovascular disease and cancer begin to rise in the population. Now, this is a primary prevention trial, meaning that people have no evidence of the diseases yet. Secondary prevention or a treatment trial would be taking people who already have heart disease and cancer and giving them a treatment to see if it makes a difference on recurrence rates or on side effects or dying from the disease. But we want to move it forward. We want to see whether people with no clinical evidence of these diseases, may we make a difference in terms of their reducing their risk of their first clinical diagnosis. Therefore, they can't have had these diseases so far. They can have not been diagnosed with them. So no history of cancer, no history of cardiovascular disease, no prior myocardial infarction or a stroke, a transient ischemic attack, which is a precursor of a stroke, angina or chest pain, or one of these revascularization procedures like coronary artery bypass grafting. Those people could not be in our study in a primary prevention trial. They also can't have had any reason why they cannot take vitamin D or fish oil or need to take vitamin D or fish oil. Because remember, we're going to randomize them against, they're not going to select it. We are going to go ahead and say whether you're going to take the active intervention or you're going to be on a placebo. So we can't have anybody in the study who needs to take one of those interventions or who cannot take one of those interventions. So they can't have had a history of renal failure or dialysis, elevated calcium levels, hypercalcemia, hypo or hypoparathyroidism, severe liver disease like cirrhosis, sarcoidosis, tuberculosis, another granulomatosis disease. We can't have those people in our study. They're going to be getting fish oil as one of the interventions, or they're going to be getting omega-3 fatty acids in the form of fish oil. So if someone has an allergy to fish, it would not be safe to put them in the trial just in case they also had a reaction to a fish oil supplement. And it also must be that they cannot be taking too much vitamin D on their own, because then with our supplement, they might be getting too high levels. So they have to be willing to stay under 800 international units of vitamin D per day. They can't be taking too much calcium, because the calcium in vitamin D may increase risk of kidney stones if they're in too high levels. So they have to be under 1,200 milligrams of calcium per day, and they can't take a fish oil supplement. So that's the population that we want to put in our study and find 20,000 of those people. And in addition, there's one more thing that's very important to us, and that is that we have ethnic diversity in the study, but in particular that we have an adequate number of African Americans in our study. And this is because of the nature of the intervention we're looking at, which is vitamin D, which naturally comes from the sun. And with a skin pigmentation that's darker, it is actually known that African Americans have lower levels of vitamin D in their bodies, and we also know that they have increased risk of cardiovascular disease. So it's going to be very important for us to have this group in whom we really want to know whether vitamin D supplementation would make a difference. They're a particular vulnerable group that we want to know whether we can be a benefit to. So we're going to want to make sure that we have an adequate number of African Americans in our study for us to be evaluating the role of fish oil and vitamin D specifically in that population. So it'll be a total of 20,000 participants in our study, 10,000 men and 10,000 women, so we can look at whether these agents work differently among men and women to reduce risk of disease, and enough African Americans in the study for us to be able to look at whether it reduces risk differently in that population than, for example, in a Caucasian population. And where did the 20,000 even come from? It came from us doing a power calculation, a sample size calculation at the beginning of the study, where we said, how many people would we need to put in the study to be able to see a 20% reduction in the development of a first cardiovascular disease or a first cancer with these agents? And by calculating, we want to have 80% power to be able to find that 20% reduction. We want to be testing at the 0.05 level, which is the common conventional level of statistical significance. And our calculations told us that we would need about 20,000 of these type of peoples for us to be able to see a 20% reduction, which we felt would be clinically meaningful, something that people would respond to and say, you know, that really does make a clinical or a public health difference. I would want to know if there's a 20% reduction in risk of these outcomes with fish oil or with vitamin D. So where do we get our people? Back to that same question. Well, one interesting thing about our study is that it's being done completely by mail, meaning we do not bring our participants into a clinic. We do not see them on a regular basis. The reason that we did that is simply because of cost. These are agents that are relatively safe. We do understand the side effects. It would be very possible for us to just mail them their vitamin D or their placebo, their fish oil or their placebo, ask them whether they were diagnosed with any of these outcomes during the last period of time by a physician. Then we can ask them to allow us to look at their medical records so we can validate or confirm those endpoints. So it's a very cost-efficient way to do this study, but it does have implications in terms of recruiting people, because often the most effective way to recruit someone is to talk to them one-on-one, to sit down with them, to tell them about the study, to answer their questions in person, to maybe be able to put up a sign in places where these kind of people might be, whether it be a church, a public building, a clinic, someplace where they're there for other reasons and they can look at it and say, well, that's interesting. That is a question I have wondered about, whether it's worth my buying these supplements and using them. This is a study I might be interested in. But we don't have that opportunity. We have to mail a letter of invitation to these people. So we actually purchased 7 million names and addresses from commercially available U.S. mailing lists. We tried to think about what kind of mailing lists might be read by people that we would want in our study. And it has to be age appropriate. So we want people who are over the age of 50 and over the age of 55. And it has to be an enhanced minority recruitment. So what would be most promising, most fruitful? So examples that we used were mailing lists of professional organizations, licensed health professionals, business professionals, other organizations such as the AARP, the Association of Retired Persons. That would be very appropriate for this age. Subscription lists of magazines or newsletters whose subscribers or individuals that might be eligible for the trial. That's what we purchased. That's who we mailed to. But the important thing to know is that only a fraction of those you invite to be in a trial are going to be willing and or eligible to actually be in the study. And depending on how much you ask them to do, the farther you go into the study telling them about it, the more you lose people who are willing. At the very beginning, where you say, just fill out this questionnaire to see if you may be eligible or not, many people will respond. But by the second questionnaire, where now you have to sign a consent form to say you're willing to be in the study and take a pill every day, people start dropping off. And after they've taken their pill for a little while to get a sense of whether that's comfortable for them and they can remember to do it, they start falling off even more as they begin to understand what it takes to be in the study. So it's hard from the beginning, it's increasingly hard over time, and it's something that we really have to concentrate on and work at very hard to get the adequate sample size in our study. The major reasons for ineligibility are not necessarily that people are already taking fish oil supplements or taking vitamin D supplements, but because they're unwilling to forego their use. Meaning that they say, I'm already taking vitamin D, I'm already taking fish oil. I don't want you to randomize me to a placebo where I will not be able to choose anymore what I do. And that's the most important aspect of a trial that limits somebody's willingness to actually be in the study. Why would someone ever want to be in a randomized trial? We really have to consider that to see what we have to offer a participant that might be a potential person for us. If this were a treatment trial, if someone is sick and they're being randomized to one treatment or another, they're actually much more eager to be in the study. Sometimes that's the only way that you could get a new experimental treatment, is to be in a trial. But they're also being followed very closely, and that gives people a lot of comfort about being in a study and being watched by health professionals to a greater extent than just usual care. And if you're coming into a clinic to be in the trial, then you're going to get some health information from being in this study. They'll measure your blood pressure, they'll measure your blood levels. You get information about your health, which many people would like to have. But what do you do when this is a healthy person who's going to be taking a vitamin and it's really not for benefit for themselves? It's actually altruism is the reason that they're going to be in it. They say, if you ask, because I want to be part of the answer. I want to be part of the solution, so that when my children get to the point where they need to decide whether they're going to take vitamin D or they're going to take fish oil, there is some evidence that they can make their decision upon. And I don't know what to do myself, but I want my family to know what to do, so I'm going to be part of your trial, which is a truly wonderful reason for people to participate in these studies. So when we talk about recruitment from an investigator standpoint, this is absolutely the hardest aspect of a randomized clinical trial. You always have difficulty identifying people who could be potential participants and getting the sample size that you need to be in the study. But it's so important because it's absolutely critical to having adequate statistical power to answer the question definitively. And again, as I said earlier, definitively is the important word. I just want an answer. I want to be able to answer the question as to whether vitamin D in fish oil are beneficial or not. Either yes, they are, in which case we will be able to inform potential users of that information, or no, it's not, in which case we can take our really scarce resources for doing studies and begin to look at something else, which in fact might be more promising.